Could we please have everyone come in and be seated so that we can continue on with the program? I'd like to thank Dr. Weimüller for giving me the opportunity to recognize one of our great members and dear colleague, Chris O'Brien. Chris has his biography in your program. In these short couple of minutes, I don't have time to enumerate all of his accomplishments, but I would like to hit some of the highlights in his contributions over his wonderful career. First, Chris has received the Order of Australia, which is the highest honor that you can receive as a civilian from the Australian government. He was the founding member and founder of the Australian-New Zealand Head and Neck Society, the first multidisciplinary society of its kind in Australia. It's a robust group that continues to thrive today. He is the recipient and has presented the Hayes Martin Lecture, the Eugene Myers International Lectureship at the American Academy of Otolaryngology Head and Neck Surgery, the Jatin Shah Lecture in Prague at the IFNOS meeting, and he will present the Seaman Lecture in England this fall. He's truly an accomplished surgeon, clinician, and educator. He's trained many individuals who are not only in Australia but have taken up positions around the world. He's an ambassador for his country and for our specialty. He's dearly loved by many of his colleagues and truly by his patients. Some of his accomplishments: he developed a very comprehensive clinical database as leader of the Royal Prince Alfred Head and Neck Cancer Program. Extensions from this database were his very important publications on both melanoma and non-melanoma skin cancer. He took the principle of sentinel lymph node biopsy, applied it to melanoma in Australia, and published a very large series which helped refine this technique and its clinical application. He developed a staging system for squamous carcinoma of the skin as it relates to parotid metastasis. And he published a very important finding that when you have a parotid metastasis, you have an extremely high risk of occult disease in the neck, which has significantly changed our management approach. He has a wonderful family. His dear wife, Gail, is here with him. He has 3 children, Adam, Juliet, and James. And if you ever spend time with the O'Briens, you'll see what a great love and bond they have with one another. In 2006, Chris was stricken with a serious illness. He's undergone surgery, chemotherapy, and radiation. But if you know Chris's spirit and perseverance, he has not in any way let that get him down. His wit is as sharp as ever. Although he left practice, he spent the last many months getting the government of Australia to commit $150 million to establish their first comprehensive cancer center at the University of Sydney, which will be a great resource for patients and investigators in Australia. Chris has recently completed a book. It's Never Say Die. He wrote this book in a short 3 months. It'll be published in October and will be about 300 pages, and I encourage all of you, when it's available, to receive it. In 2007, the Chris O'Brien Fund was established. It would not have been possible without the help of Pat Gillane, Ernie Weimüller, and the support of Greg Wolf. The fund now has over $130,000 committed, and the proceeds of this fund will be used to support the Chris O'Brien Lectureship at the international meeting every 4 years, and we're proud that Don Morton, a world authority on melanoma, will be the first recipient of this award. We have also established a Chris O'Brien Traveling Scholar Award so that every 2 years an academician or clinician from Australia will travel to the United States, and on the other rotation cycle, one of our members of the American Head and Neck Society will travel to Australia to visit institutions, share their knowledge with their colleagues, and help us form stronger bonds between our two countries and our societies. So without further ado, I'd like to recognize Chris and his wife Gail. Chris, if you could stand for us, please, and Gail. And I failed to mention that Karsten Palm will be the first recipient of the Chris O'Brien Traveling Scholar Award. Kirsten will be traveling in the United States for the next Head and Neck Society meeting, and he will visit 3 institutions in the United States. So congratulations to Karsten as well. Eric, I'll turn the podium over to you.
Thank you, Randy. So I have the pleasure and honor to introduce Dr. Donald L. Morton. Dr. Morton is a renowned clinical scientist and surgical oncologist. His discoveries have profoundly changed the treatment of human cancer. His pioneering work in intratumoral BCG for melanoma has represents the first successful clinical application of immunotherapy in human cancer. His innovative studies of sentinel node mapping changed the standard of care for patients with melanoma and other solid tumors. Dr. Morton has received NIH peer-reviewed research for 35 years, and in the year 2000, he topped the list of clinical investigators who received the most grant funding from the NIH. He has more than 600 publications in peer-reviewed journals and his numerous prestigious awards and honors. Dr. Morton is the past president of the International Sentinel Node Society, the past president of the Society of Surgical Oncology, the past president of the World Federation of Surgical Oncology Societies. Dr. Morton was chief of the Division of Surgical Oncology at UCLA before he established the John Wayne Cancer Institute in Santa Monica, California. As chief of the melanoma program, Dr. Morton has guided the Institute to become the internationally respected melanoma center that it is today. As director of the Surgical Oncology Fellowship, Dr. Morton has trained over 100 fellows, most of whom now have academic positions in medical centers throughout the world. So, Dr. Morton, we look forward to your lecture and welcome.
Thank you very much, Dr. Sturgis. I must say that I am somewhat overwhelmed by the honor of being the Chris O'Brien lecturer. And I'm so impressed about the level of science that I've seen exhibited at this meeting. I congratulate you all. And Chris, I've known not very closely, but since we started the Sentinel node trial that I'll talk about more subsequently. So if I could have the next slide, please. Is there, oh, here it is. What I'm going to talk about today, and I must say I spent a lot of time in trying to decide what would be an appropriate talk. And I finally decided that perhaps the most interesting thing for you would be discussion of the development of sentinel node biopsy for melanoma. And as you know, subsequently, it has been found to be a universal principle that's applicable to any solid tumor that metastasizes through the lymphatics. We'll begin with a review of the management of regional nodes in melanoma, and then talk about the John Wayne experience and the results from MSLT1 in sentinel node biopsy, review the technical aspects for head and neck, and talk about the prognostic significance. Now, I'm going to present the results up to the third interim analysis of the multicenter sentinel node trial. I will say at the beginning that except for one aspect of the data, which I will speak about, the results for melanoma at all sites are very close to that for head and neck. The head and neck melanomas in the multicenter trial make up almost 17% of the total population. And I would say, as you'll see when we look at the distribution of patients from throughout the world, that certainly the Sydney Melanoma Unit and Dr. Chris Bryan is responsible for many of the patients in the trial. And so the role of complete lymph node dissection in primary melanoma has been debated since 1892, when Herbert Snow first proposed that since there was frequently lymph node metastasis in primary melanoma, that if weren't excised at the time of the primary would subsequently appear, that everybody ought to have a complete elective lymph node dissection up front. And unfortunately, I have to say, 100 years later, this whole question of lymph node metastasis in melanoma remains controversial in some centers, and we will talk about this later. But because multiple randomized trials have failed to show an overall survival benefit, and we will talk about why that might be so as we go forward. Now, the management of the regional nodes really falls down into two conflicting hypotheses about their role. There's the incubator hypothesis, which I believe is correct, is that the primary melanoma, and we've shown this, sends immunosuppressive factors through the lymphatics to the first node. And that node is immunosuppressed as compared to other nodes in the nodal basin. But this immunosuppression then allows the melanoma cells to establish growth in the sentinel node. And from there, they spread to other non-sentinel nodes in the nodal basin and through the bloodstream to distant sites, which then leads to distant metastasis, which is the cause of death. Now, the other hypothesis is that basically the sentinel node has nothing to do with the etiology of distant metastasis, that they all come directly from the primary, which goes to the sentinel node and distant sites simultaneously. So finding tumor in the sentinel node merely indicates that this melanoma has the ability to metastasize. And it's, so that it has no therapeutic relevance if that were correct, because removing the node is not going to affect the distant metastasis. So that really is the problem. Whereas under the incubator hypothesis is that rarely does the metastasis go directly from the primary tumor to a distant site, and that's primarily in thick melanomas that are 3.5 to 4 millimeters or thicker. So if we look at the two, prior to sentinel node biopsy, there was two ways of dealing with this. One is that, as according to Snow, everybody gets an immediate complete lymphadenectomy. But in that case, only 20% of patients have positive nodes, which means 80% of patients have a radical lymphadenectomy, which can provide no benefit from it because there's no tumor there. And so the other approach is to watch and wait with observing the nodes, and 20%, more or less, depending on the thickness of the melanoma, will develop clinical nodal metastasis and have a delayed lymphadenectomy. Now, the problem there is there's often multiple involved nodes at that time and more likely distant metastasis. But 80% of patients that have no nodal metastasis will remain well. Now, these metastases, although most of them occur early, they may be delayed for 8 to 10 years. So it means the patient has to be carefully followed for a long time. So when I looked at this problem about 20 years ago, I decided that, this approach of removing all the nodes makes no sense. 80% can't benefit, and this approach destines patients to clinically positive nodes and a higher death rate. So I thought that the answer to the dilemma was to develop a non-invasive way of determining which patients had nodal metastasis and which didn't. And so we developed sentinel node biopsy, and we have found that about 16 to 19% of the patients in prospective trials will have positive sentinel nodes and can have immediate lymphadenectomy. And those that are negative are observed, and about 4% of the negative patients will develop nodal relapse with the technology that was available from 1994 to 2002 for finding the sentinel node. But 80% then remain free and have had really a wide excision and a minimal sentinel node biopsy, which I'll show you. Now, one of the things we learned early on is that this was not a see one, do one procedure, as is often the case in general surgery. But it requires a multidisciplinary team and of a nuclear medicine physician to show where the metastases are going. In the head, neck, and trunk particularly, you may have multiple unexpected areas of drainage. A surgeon that's very meticulous about following the lymphatic channels and finding the node, and then a pathologist who's willing to make multiple sections of that node and with special stains to look for metastasis. So one of the first questions that we were concerned about is, does the sentinel node accurately identify occult metastasis that will grow to palpable size by watch and wait? And of course, the only way to answer that question was to have a randomized trial where patients were randomized to sentinel node biopsy and complete node dissection versus wide excision only in observation. So theoretically, the total incidence of metastasis in this arm should equal the total incidence of metastasis here. Now, we randomized 60-40 because we wanted the sites in the trial to get as much experience as possible with sentinel node biopsy. And then patients were stratified by site, extremity, non-extremity, which included head, neck, and trunk, and Breslow thickness. Now, based upon the John Wayne database, looking at elective lymph node dissection, we thought that there was most likely to be an overall difference in the 1.2 to 3.5 millimeter thickness. And this is based upon a database that now contains about 14,000 patients. I think it was about 12,000 at the time this study was done. And then in thin lesions, because we thought the incidence of nodal metastasis would be small, and we didn't see any difference. And in thicker lesions, we didn't see any difference, where we assumed that was because the metastasis had gone to the node and on to distant sites, or had gone directly to distant sites. And so whatever you did with the nodes at that point wasn't going to change the outcome. Well, between 1994 and 2002, we randomized 2,001 patients. And I showed this slide to show you the significant contribution of our Australian colleagues to this trial, and how it would have been impossible to do this trial just using U.S. patients. Because what happened in the U.S., unfortunately, is once it got publicized and we taught the centers how to do it, why the American patients didn't want to be randomized, and it became a marketing tool. So people were sent to the center to get the sentinel node biopsy. But thank God we had Australia, Europe, and the EU in addition to the U.S., and so we got the projected accrual that we needed. Now, because we were concerned about the difficulty of the procedure, we insisted that each site did 30 learning cases where they found the sentinel node, and then they did a complete node dissection. And to confirm that the sentinel node accurately reflected the basin in that particular center. And they had to have 90% accuracy. And then we reviewed centrally lymphoscintigrams and the pathology. And it was only after finishing those 30 cases that patients could be randomized. Well, in terms of quality control, the surgeon's idea as to whether he had found the sentinel node was very high for groin and axilla, but notice for neck, there was about 1 out of every 6 patients. They couldn't find the sentinel node in the neck, and we'll talk about why later. But it was very clear that there's a significant difference there in the surgeons finding the sentinel node. Now we're going to talk about patients in which the surgeon thought he had found the sentinel node, and whether he really did or not, or found all the sentinel nodes, based upon the recurrence rate in a node-negative basin. And so this is the question: does a negative sentinel node accurately identify patients without regional nodal metastasis? And we knew at this time about 2 to 5% of negative node basins would have a nodal recurrence. But in the head and neck areas, we'll talk more in a bit, even though the surgeon was less likely to find this, what he thought was a sentinel node, the recurrence rate in the node-negative basin was 9.4%. Now, here shows the entire series of all sites in terms of patients entered into the trial. And notice, even though all these sites had had 30 learning cases, there was a 10% false negative rate in the first 25 cases at each center. Whereas after 25, it fell to 5.2%. So this would suggest, at the time this trial was done, 55 cases was what you needed to get down to a reasonable false negative rate. Well, this contrasts head and neck with axilla and groin. And here you see that in MSLT1, out of 149 patients, there was a 9.4% false negative nodal recurrence. Whereas in the axilla or groin, it was only 3.4%. In the John Wayne, we had 3.4% in the head and neck area, and 1.7% in the other sites. So it's very clear that the most experienced center at the time this was done had the lowest rate, and then the volume of cases in the head and neck was so much smaller than other sites that the head recurrence rate was high. Now, when we looked at this, we thought it's either a surgeon area, the surgeon didn't find the sentinel node, or it's a pathology area. If you think about it, a 6 millimeter node will produce 1,000 serial sections, but the pathologist typically, by this technique, only examined 12 to 20 sections. So it's possible that he would have a geographic miss. And we wanted to try to find ways to control for that, and we came up with the use of carbon dye, which stayed with the node and confirmed that this was a sentinel node, and secondly, told the pathologist where he needed to look in the node. Because we thought it's possible that the node may have a geographic localization similar to the nodal basin, that there would be compartmentalization of the drainage in the sentinel node itself. So if this was the case, the tumor cell localization would be highly localized to a specific site and may result in a geographic miss if on the random sectioning of the node by the pathologist. So this is the concept. In order to test this hypothesis, we used carbon dye that was mixed with the blue dye. At the time, it was injected beside the melanoma, and the concept is that the carbon particles would be only in one part of the node. Now, what led us to this is that, although I didn't recognize the significance for quite a while, is that we noticed often only one part of the node would be blue. When we looked at it intraoperatively. And this is a case where we inject a carbon dye, and it shows a nice localization of the carbon here. And then you can see the blue dye on this northeast corner of the node. And there the counts are very high, but you go down here, the counts are low. And if on the cross-section, you see the dye is up here, there's no dye down there. So now what really proved the concept was that in something like 100 consecutive cases where there was tumor in the node, the carbon particles were located in close proximity to the tumor cells in the node. So the carbon then not only confirms that this is the sentinel node for the pathologist, because the blue dye disappears in the processing. But they can see the carbon to tell it where it is. So when we first started doing sentinel nodes in head and neck, we had simple cases like this: the primary here on the scalp, and there was a sentinel node here. You see the lymphocitogram, and then at the time of surgery, you had this nice lymphatic channel coming to the sentinel node. And here's another case of a primary on the cheek, the sentinel node down here submandibularly, so that when we created our flap, we could get to these sentinel nodes. A relatively simple drainage pattern, and not a problem. But as it turned out, we do more and more. We see very complex drainage patterns with multiple nodes and basins. Here's a case that the posterior neck, and you have drainage adjacent to it on the left side, and you have a supraclavicular node on the left side, and then here's a right axillary node. We would have never dreamed that if we didn't have the drainage pattern. So we had to go after all three. And face and scalp lesions can be difficult. The nodes along the facial nerve. And here's an example of a auricular primary. And you can see the nodes that are marked by the lymphoscintigrapher and up around the parotid and down here. Now, at first, we thought these are not primary drainage nodes, they're secondary drainage nodes. And the primary were here. But when we began to follow these patients and get recurrences down here where we hadn't gone after those nodes, we learned that you really have to go after all the nodes. Here's a post-auricular primary draining both to the parotid and down the posterior neck, as you can see here. And here's a scalp, a forehead primary, and you can see multiple preauricular and high jugular-digastric nodes. So the other problem is when you have a primary in the neck or close to a drainage basin, the shine-through activity from the primary may obscure the nodes. And we then finally learned to excise the primary site and look again with the probe. And I want to show you, this is the problem. Here you got a primary in the neck, you got this big blackout, and you can find 2 nodes here, but are there others there? And I just want to present a case of mine that 42-year-old man, lateral neck primary, 1.5 Clark, and ulceration, so it would be a 2A, and a clinically negative basin. And here's the lymphoscintigram. There were actually 6 nodes we can find around the periphery. We inject the primary with isofulfin blue and carbon dye, peritumorally. We identified 6 nodes. I was very proud of myself. I found all the nodes. They were all negative for metastasis and all contained carbon, indicating that these were truly sentinel nodes. So AJC stage 2A with negative sentinel nodes. And we followed the patient. This shows the carbon in every one of the 6 sentinel nodes, so confirming it's a sentinel node. Well, 19 months later, the patient developed a recurrence in the neck. I did a radical neck dissection, and we found 3 out of 60 of the nodes had metastasis. So, my goodness, are these upstream metastases that had, or are they really truly sentinel node metastases? So I asked the pathologist to go back and look at these metastases for carbon. And what do you know? 2 out of 3 had carbon in the node with the metastasis. So therefore, this patient had a total of 8 sentinel nodes, 6 we identified the biopsy, and 2 in the nodal recurrence. So there was 1 upstream node that had further drainage. So the question is then, does this watch and wait observation period, if you observe the nodes, allow these occult metastases to grow to detectable size and spread to other nodes within the lymphatic basin? And the answer is yes. And we base that on the fact that if you do immediate complete lymphadenectomy with a positive sentinel node, you find an average of 1.4 positive nodes. However, if you wait to 19 months till the node becomes clinically detectable, now you have an average of 3.3 nodes. And with in the false negative patients, it's a 4.3 nodes. So delayed lymphadenectomy results in spread to more nodes as compared to immediate. And this classical slide from Charles Ball shows that with increasing number of nodes, you get decreasing survival. So the data suggests that if microscopy are left alone at one time, become clinically apparent, spread to involve multiple nodes. Now, in terms of morbidity of the procedure, when we looked overall, the patients had a wide excision or wide excision plus sentinel node. There's no significant difference in any complication. So the morbidity of the procedure is very small. What's the prognostic significance of a positive sentinel node? This is in the primary AIM group, and as you can see, the hazard ratio is 3.0, highly significant, difference between a sentinel node negative and a sentinel node positive patient. And even in thicker lesions, there's a difference in prognosis that's highly significant, and essentially the same hazard ratio, amazingly. By a multivariate analysis, you see both a disease-free and overall survival. This includes all thicknesses. The sentinel node status is the most important prognostic factor. In the multicenter trial, the subset of head and neck patients, we see the same thing. The risk ratio actually for a positive sentinel node in head and neck is 5.47, and at 5 years it's 88% versus 59%. So we conclude that as far as head and neck and other sites, sentinel node status is the most important prognostic factor. The head and neck is the most complex and difficult. The learning curve is not steep. It's not a C1 do one procedure. Results depend on volume experience, and we think that patients are best served by having a team in each center that concentrates on melanoma in the head and neck and achieves a high volume. Now, what is the effect on the overall survival? Well, this is looking at the entire population, whether they had nodal metastasis or not. So you're treating, in the case of the multicenter trial, you're treating with a complete lymphadenectomy the 16% of patients you found positive sentinel nodes. The 84% of patients that had negative sentinel nodes are getting no treatment. So the question is then, what effect does treating this 16% with immediate lymphadenectomy have on the overall disease-free and overall survival? And this group is the one that one would expect a difference if there is one. And obviously those that have no nodal metastasis can't really be affected one way or the other, which make up the majority of the population. Well, on disease-free survival, in the intermediate thickness, there is a hazard ratio of 0.74 in favor of sentinel node biopsy and early completion lymphadenectomy, with a p-value that's very significant. And at 10 years, it's 64% versus 72.5%. Even in the thicker lesions, you see a difference in disease-free survival that's statistically significant. Not as many patients, so the p-value is not as high. How about distant recurrence? Because that's what kills people. A local disease in melanoma is usually can be controlled. And we see that if they have no nodal metastasis, either by sentinel node biopsy or in no nodal recurrence, the survival is exactly the same. Where if they have a positive sentinel node versus a delayed lymphadenectomy for observed positive node, the hazard ratio is 0.55, highly significant. There's no difference in the patients that were randomized to observation delayed lymphadenectomy versus those that had a negative sentinel node in recurrence and delayed lymphadenectomy. So, and in the thicker lesions, we see the same trend, but it's not significant. P-value is not significant between a positive sentinel node and delayed. But in the non-nodal recurrence and negative sentinel node, there's no difference as before. Now, the number of patients with head and neck in the multicenter trial was not sufficient to look at overall effect on survival at this point, but we had 307 patients that we were able, in the John Wayne database, Breslow thickness, site, and nodal status. As you can see, it looks like that the sentinel node patients do slightly better, even with 307 pairs. This is not significant at this point. Well, here is where, if there's going to be a difference, that we should see it. And so to summarize overall, we have a difference in disease-free survival, but not overall survival. So in the node-positive patients, we see that those that had nodal recurrence, 36.5 versus 58.4 in the sentinel node positive patients, a highly significant difference in favor of early lymphadenectomy. And if we look overall at the three subsets, the results are very similar. Sentinel node positive, much worse survival than sentinel node negative. Sentinel node positive, better survival than nodal recurrence. And in the 3.5 millimeter group, as we predicted, there would not be a difference in survival. There is a slight difference in favor of the sentinel node positive group, but it's not statistically significant. Now, one of the things that recently we have found is that, surprisingly, there's a relationship between the diameter of the metastasis in the sentinel node and the survival. And this is based upon John Wayne positive patients and the patients in the MSLT1 trial. And as you can see, if the node is negative, it's 88% 10-year survival. If it has a metastasis smaller than 0.1 millimeter, it's 81%, 0.1 to 2 is 73, so forth. Lesions thicker than 4 millimeters have only a 41% 10-year survival, 4 millimeters, making up about 10% of the total in the John Wayne database. And in the MSLT1 trial, Dr. Cochran used a different categorization, but the results are essentially the same. Thinner than 4 or 5 millimeters do pretty well. The thicker ones do not so well. It turns out also that there's a relationship between the thickness of the metastasis and the chance of finding additional positive nodes when you do a complete lymphadenectomy. And as you can see, it's about the number of nodes is it's about 10% increase additional nodes, and finding the nodes is about 0.7% to 10% chance up to 2 millimeters. So even the very thinnest lesion has some additional metastasis at completion of lymphadenectomy. Looking at the MSLT1 and MSLT2 trials, you can see 11% and 16% have sentinel node metastasis thicker than 4 millimeters. And so it's surprising that the volume of tumor in the sentinel node has such a profound effect on the chance of finding additional positive metastasis and survival. So we concluded there's a strong correlation between the size of sentinel node metastasis and both disease-free and overall survival. Even Mets thinner than 1 millimeter might have additional non-sentinel node metastasis. 90% of the sentinel node metastases are below the level of ultrasound detection. There has been some advocates in Europe that suggested that you don't need to do a sentinel node biopsy, just do ultrasound. If you wait till you can detect something on ultrasound, you've dramatically reduced the chance of that patient having long-term survival. And we now need to go forward in terms of stratification and adjuvant trials. looking at the size of the micromap. So in concluding, we think this procedure of sentinel node biopsy and selective complete lymphadenectomy is the answer to the century-old dilemma in the management of primary melanoma. It stages the regional nodes with 95-98% accuracy with experience, identifies clinically occult sentinel node metastasis for immediate lymphadenectomy, but whereas watch and wait, allowing you to grow to the palpable size, doing a delayed lymphadenectomy allows involvement of more nodes, and we found that 93% of these patients that are observed require a complete lymphadenectomy anyway, and the ones that didn't have a complete lymphadenectomy had to have radiation therapy or some other palliative treatment. Delayed lymphadenectomy was shown has significantly more complications than immediate lymphadenectomy. Prognosis is a very important prognostic factor in disease-free survival, prolongs disease-free survival. The entire population avoids the anxiety of recurrence and destines the patient to have long-term, frequent, every 3 months follow-up. So for up to 10 years. At 10 years, the incidence of nodal metastasis in the observation group and the sentinel node biopsy group are exactly the same. So we think that the argument that these metastases are not biologically significant is not valid. Prolonged melanoma-related survival in patients with nodal metastasis, 10-year survival 63 versus 36, hazard ratio of 0.9, and a highly significant p-value. So that summarizes for you the present status of this sentinel node biopsy in melanoma. We have a fourth interim analysis and a final analysis yet to go in this multicenter trial that we started some 13 years ago. So it's been my privilege to be part of the development of a translation of this procedure, which I first thought of some 23 years ago, to have the opportunity to carry it into the clinic in phase 1-2 trials and then complete this phase 3 trial. It would not have been possible without the participation of our colleagues throughout the world. And I think that's one of the really wonderful things about surgical oncology, is that, as was said earlier this morning, it's by grouping together and fighting our common enemy that we're going to win. Thank you very much.
Could